we all know that anti-BCMA CAR-T is a very efficient therapy for myeloma. It's already proved, and it's already outperformed other good previous standard of care therapies for third line and even a second line. And there are two FDA-approved CAR T-cell therapies for multiple myeloma, both targeting BCMA, and there are other targets that were already tested and showed also good results. But the caveat is the limited availability for CAR-T. It's not like an off-the-shelf drug. It's a product that is manufactured for each patient personally, and there's a big problem with slots, and there is a long vein-to-vein waiting period for this therapy, and also what we call financial toxicity, because it's very, very expensive. And this is where academic point of care CAR-T, like our CAR-T in Jerusalem, may play an important role on solving this problem of all these three problems, actually. So this is the rationale for even, starting and testing this therapy. And we, like other centers in the world, started a whole process of generating our CAR-T, our center CAR-T, starting with in vitro, like lab studies, and going all the processes and approval to a first-in-human clinical study of anti-BCMA CAR-T. And we have a phase 1A and 1B study. We already treated actually more than 120 patients. And here we summarize the data for the first 84 patients who received a higher dose in this CAR-T. Like every phase 1 clinical trial, we started with lower doses, and this is the data summarizing the higher doses. So maybe I can talk about this efficacy and toxicity that we saw. So starting with the toxicity, maybe like every phase 1 study, we want to start with that. So overall, the toxicity was quite similar to other CAR-T that we know, and even less. CRS was very common, of course, in 95% of the cases, but it was mostly of grade 1 and 2. There were 19 cases of grade 3, but no cases of grade 4 and 5 CRS, with very liberal use of tocilizumab. And we had only 3 cases of ICANS, which is 4%, and all three cases were grade 1 and 2. We didn't have any treatment-related death in the study. Hematological toxicity was very, very common, but persistent grade 3 or above cytopenia were extremely rare. And infectious were, of course, common, but we had only 8% of grade 3 or above infections. So overall toxicity was similar or even better than other CAR-T. I should mention that population in our study was actually of much frailer patients compared to the registrational study of both commercial CAR-Ts, the Karma and the CAR-T1, and actually 48%, so almost half of our population would not have been eligible to both studies, to Karma and to CAR-T1, because of a few issues. Our thresholds for including patients were much lower: platelets count, creatinine clearance, performance status, etc. So our population was more close to real-world data, I would say. So going back to the results, I discussed the toxicity and the efficacy. Our response rate was 92%. 55 of them was CR or stringent CR, and 74% were MRD negative, 10 to the minus 5 by flow cytometry. And with a year of follow-up, the median progression-free survival was almost a year, 11.6 months, and the median overall survival was not reached. Yeah, this is about it in a nutshell.